Good morning everyone. Welcome to Unacademy where you can crack all NEET PG exams with us with our top educators, quality content and have a great learning experience. So guys, let's crack NEET PG together. A little about me. I am Dr. Sasha Menin Remedies. I've done my MBBS from Father Muller Medical College, Bangalore. I have 2 publications and 1 paper presentation in the field of anesthesia. I've been working and teaching in Bangalore for the past 2.5 years. Today's topic is a continuation of yesterday's topic, which is patient positioning in anesthesia. And I'll just brief you all on yesterday what we did, and we should continue with today's topic. So, little about Unacademy. It's one of India's largest learning platforms where you can get plus subscription and access to unlimited live and recorded courses from India's best educators. And so hurry guys, get your subscription, don't delay. So what will you get out of Unacademy? So we have our daily life classes where you can chat with your educator, engage in discussions, clear your doubts and answers, and all this is while the class is going on. These are all structured courses. So basically what I meant to say is, like, when you go to a coaching institute, you waste time, energy to get up, get ready, reach there. Once you're there, it's very difficult for the educator to clear everyone's doubts because it's a large, first of all, these are huge classes. The educator has a stipulated amount of time in which he or she is supposed to finish whatever they have been designated to finish. So it's very difficult to clear everyone's doubts, and not everyone's doubts can be cleared. Whereas at Unacademy, during the class, you can text us, and we are here to clear your doubts and help you all through this time. Then these are all structured courses. Excuse me. These are all structured courses. That means your educators have uh, the educators have prepared these courses in line with your exam syllabus. They have researched, and each one of these courses is made in line with your syllabus. And whatever is best for from a NEET PG point of view, that's how the educators have uh, done this. Now you have your live, we conduct live tests and quizzes. So basically, after a couple of topics, we'll take a test and then we take a mega test so that it becomes easy for you all. It's like a revision for you all, so that uh, basically basically it's a revision so that you all can update it, and after every class basically have a test so that it remains fresh in your mind, because at the end of the day, cracking this exam is all about practice and revision and coming back to the thing, right? Then there is unlimited access. One subscription gives you access to all our live and recorded courses, and you can watch from the comfort of any of your devices. So wherever you all are sitting, whether you all are at home, wherever you all are, from the comfort of your home, you all can watch the classes. These are some of the top educators: Dr. Nikita Nanwani, Dr. Mohammed Zam, Dr. Mishra, Dr. Sharma. Dr. Nikita Nanwani, of course, is a PG mentor. He's a mentor for radiology as well as mnemonics and concept, focusing on certain must-know topics which encompass all subjects. So it's a mnemonics is again if it does you all good, it's very good. You all should actually uh, what you say, apply for it, like go for it. And if you all can make your own mnemonics, that's like the best. There's nothing better than that. If you all are capable of making your own mnemonics, I would highly recommend you all going for it, because that is the best, making your own mnemonics. Then these are some of the courses offered. As you can see, there are about 19 subjects that you all have to cover. And yes, I know NEET PG is not easy. You all have done all these subjects over 4.5 years. You're on a stipulated amount of time. You all have to revise these subjects quickly and give your exams. It's not easy. It's a lot of pressure, I know. But these are various courses offered under these subjects. Now, from the subject point of view, I would say Now, as you see, anesthesia, psychiatry, radiology, they were known as small subjects. Basically, you all didn't have to study them in detail. You all didn't have to so you all didn't have to study them in detail. It was just like, the icing on the cake, basically. So y'all didn't have to go into depth into it and all that. So y'all really don't know, but these are very vast subjects, and it's not easy to clear your exams without going through these subjects, right? And these are allotted around 11 marks each. But these 11 marks are very easy to score. So like how you all just had to do the icing on the cake, even for the exam, they do not go into much depth because you all have not gone into much depth per se into these subjects. So they also do not go into much depth into these subjects when giving your questions, whereas your anatomy, physiology, etc., of course they'll go into a lot of depth, right? Because you'll have spent a year studying this, you all should know the in and out of it. So they can ask you anything for anywhere, and of course it's allotted 44 marks. But the thing with these subjects like anesthesia, physio, and all that, they're very scoring. The thing is, they're very scoring subjects. So these are highly scoring subjects. So it really helps you all. If you don't miss out on these 11 marks per subject, each of these subjects, you're scoring a lot of marks, right? So don't miss out. This is where you can score. So now these are some of the ongoing courses on our platform. Um as you can see, course on neurophysiology, course on GI surgery, cardiovascular surgery, uh, course on pathology, respiratory system, a course on larynx. These are the various courses that are there on our platform. Then, as you can see, there are now coming to the subscription. There are five types of subscription on the screen, and those of you who are giving those of you who are giving those of you who are giving the exam this year, please guys go ahead. I mean, the 6 months should suffice for you all, I would say. I mean, the 6 months, those of you who are giving the exam this year, I think that should be enough. But the rest of you who actually want to drop a year, etc., I would highly recommend that. I mean, it's great, there's nothing wrong. I dropped a year, there's nothing wrong. Drop 2 years also, there's no problem. Nobody's going to ask you at the end of the day how long you took to crack NEET PG. Nobody cares about such things. It's all about practice. It's all about medicine is all about practice, and clearing this exam is also all about perseverance and hard work and lot of revision and practice. So your 12 and 24 months more economical too, because after 6 months, if you want to go through the courses again, you'll have to reapply, you'll have to pay again. So again, that's a big hassle. So I mean, you'll have to pay the entire amount again. But whereas your 12 and 24 months, you of course have that buffer period. Now, as I said again about those subjects, anesthesia, psychiatry, and all that, we never really went into detail, right, during MBBS. So none of us knew what the subjects have. So while studying these subjects, you actually have an idea about what these subjects have, and uh, your scope is broadened as to what you would want to take. See, otherwise you will be fixed in your head that okay, no, I want to take medicine, no, I want to take orthopedics. But when you do these subjects, your scope, your mind is broadened as to like, okay, maybe I can do these other subjects too, right? Maybe I don't want to do medicine, maybe I want to take up ophthalmology, or maybe I want to do psychiatry or anesthesia. So when you study, I'm not only talking about these anesthesia and all that, these subjects which you do not do during MBBS undergrad, even the other subjects, unless you actually read them again, you'll not know. So it actually helps you gauge. For me, it did that. That's why I'm telling you from personal experience. It helps you know what you want in some cases, not for everyone. you're doing this for the rest of your life, so heck, you'll better enjoy what you'll do, right? Otherwise there's no fun in doing it. So that's why I feel it's important. Use my code, avail a 10% discount. Okay, as you can see, a 10% discount even over here, and the discount applies to all. Again, as you can see, use my discount, 10% off you will gain. uh, just a sec, guys. Okay, so okay, so now we will proceed with our class. So basically, we just run through what we did yesterday. So patient positioning is a major responsibility. Basically, I told you, a major responsibility that has to be shared by the entire operating team, which involves the surgeon, the nurse, and the anesthesiologist. Sometimes certain patient positions will be required where there will be extremes of position so that there can be adequate surgical exposure, and in these positions there can be a lot of physiological changes which can be in the patient, lot of, because of the position change, extremes of position change, there can be a lot of physiological changes occurring, and it can be very harmful to the patient. So a compromise has to be reached between the surgeon, the anesthesiologist. So basically, a compromise has to be reached between the surgeon and the anesthesiologist as to the optimum position where the surgeon, where it will be an optimal field for the surgery for the surgeon, as well as so there should be an optimum view for the surgeon, as well as there should be uh, so optimum view for the surgeon, as well as there should be no, not that much of physiological changes occurring. So why do we bother with positioning is because there are a lot of cardiovascular and respiratory changes that occur, physiological changes that occur with position, a lot of compensatory changes which occur, and with anesthesia these compensatory changes get blocked. So a lot of physiological alterations basically occurring. Uh, So, like I said, positions deemed optimal for surgery usually result in undesirable physiological changes, putting the patient at risk. So, the patient is the primary concern, not the position is secondary. If the patient's safety is compromised, there is a big no to the position. So, wherever possible, basically the goal is when the if the patient were awake, he would tolerate the position best. I mean, the whatever the position is, in this position the patient would be most comfortable when awake. So we need to aim for such a position. So certain surgeries are like extremely long, so this should be anticipated by the anesthesiologist, so better to ask the surgeon how long the procedure will take, etc. Because certain procedures, when they prolonged, there can be a lot of tilting of the table, head up, head low. So if your patient is not strapped, he or she can slip off the table. Highly unprofessional, medico legal if the patient falls off the table. So great care has to be done. The patient safety straps are put. Now coming to the physiological changes, so various arterial, venous and cardiac physiological changes occur. So basically human beings are upright beings, so when they the vertical distance from the heart to the brain uh, is, there is a distance basically from the heart to the brain, right? It's not at the same level unlike in animals. So because of that, a constant perfusion has to be maintained between the heart and the brain. So you cannot allow hypotension and all to occur, because it will first it will highly affect, because the perfusion will be lost. Because of the upright position, there will be more changes. So constant perfusion has to be maintained. This has to be kept in mind, especially when the compensatory changes are blunted. So normally in a normal patient before anesthesia, when a patient return from supine, when a patient from standing position reclines basically to a supine position, venous return to the heart will increase, because when standing there is there is pooling in the legs. So when the patient lies supine, the blood from the legs, from the lower extremities, redistributes towards the heart. So the preload will increase, your stroke volume will increase, and your cardiac output will increase, right? Because of the increase, basically because of the increase, the pool blood from the lower extremities redistributes towards the heart. Now now any increase in arterial blood pressure, and so basically when the preload comes back to the heart, when you saw that, right? I'm sorry. So increase in preload, stroke volume, cardiac output, basically all these will eventually lead to your increase in blood pressure. So these will eventually lead to your increase in blood pressure. So with this increase in blood pressure, your afferent baroreceptors, basically your aorta and carotid sinus, so the afferent baroreceptors get activated, and this causes an increase in the parasympathetic activity. So this will cause an increase in the parasympathetic activity, as you can see. So it causes an increase in the increase in the parasympathetic activity, decrease in the sympathetic outflow. So the compensation is basically decrease in your heart rate, decrease in stroke volume, and decrease in cardiac output, ultimately leading to a decrease in blood pressure. So basically the blood pressure is maintained, right? It shouldn't be too high, it shouldn't be too low. So the compensatory mechanisms bring it back to normal. And there are various mechanoreceptors in the atria and ventricle, which also decrease the sympathetic outflow to the muscle and flanking beds. Atrial reflexes are activated. Uh, so atrial reflexes are activated to regulate renal sympathetic nerve activity, plasma renin-A, NP, and arginine vasopressin level. So basically, at the end of the day, the blood pressure is maintained within a narrow range with postural changes in an unanesthetized setting. But with general anesthesia, muscle relaxation, neuroaxial blockade, positive pressure ventilation, all these compensatory mechanisms are basically lost. Now with the ventilation, with positive pressure ventilation, that is basically mechanical ventilation, there is a raise in the intrathoracic pressure. So there will be a decrease in your venous return, decrease in cardiac output. Even PEEP, when applied positive end expiratory pressure, will increase the intrathoracic pressure. Conditions will decrease the lung compliance, such as asthma, obesity, airway diseases, basically obesity, light flames of anesthesia, ascites, all increase the mean intrathoracic pressure, which decrease cardiac output, venous return, and lower the BP. So basically general anesthesia will lower the blood pressure, which can affect your perfusion to the vital organs. So this has to be maintained, it is critical. So that's why arterial blood pressure is usually labile at induction and during patient positioning. So at induction, basically all the inducing agents also bring about, they bring about this change in, uh, they are bring about the change in blood pressure and heart rate. So that's why the arterial blood pressure is most liable during induction, and of course during patient positioning, why we discussed it. So any interruptions in monitoring should be any interruptions in when monitoring, any monitors which are taken out should be put back on the patient immediately. Now anesthetized patients who are breathing, basically anesthetized patients means they are sedated and who are breathing spontaneously, they will have shallow breaths, not deep breaths, shallow breaths. So there will be a decrease in tidal volume, there will be shallow rapid breaths, decrease in functional residual capacity, and increase in the closing volume. So any position that limits the movement of diaphragm and chest wall may increase atelectasis and intrapulmonary shunting. So basically, when an individual shifts from the standing, so when an individual shifts from the standing to supine position, right? So an individual is basically standing. So when the individual shifts from the standing to supine position, the functional residual capacity decreases owing to the cephalad displacement of the diaphragm. So when the patient is lying down, the diaphragm moves upwards, so the functional residual capacity will decrease. The contribution of ventilation of the chest wall compared with the diaphragm, so the contribution of chest wall also decreases. And of course, there is preferential, because of gravity, preferential perfusion of the lower zones of the lung. So this basically leads to a ventilation perfusion mismatch, because perfusion is occurring basically to the lower zones and ventilation is decreased. Now coming to specific position, so the supine position, the hemodynamic reserve is best maintained in this position because the entire body is close to the level of the heart. Compensating mechanisms get blunted and any change in position can cause extreme changes. So basically in this positioning, the arms may be tucked by the side or abducted. If they are abducted, they should not be abducted more than 90 degree to decrease brachial plexus injury. The bony area should be padded adequately, and yeah, that's about it. Then the hand and the forearm can either be supinated or kept in neutral position with the palm towards the body. This is basically again to reduce external pressure on the spiral groove of the humerus and the ulnar nerve. The elbows and any protruding objects like intravenous fluid, lines and stopcocks should be padded, basically to prevent pressure in case they come under the patient. These are the variations of the supine position. So you have your lawn chair position. Your legs and knees are slightly flexed, and basically this increases the venous return to the heart, and also the heart and the pubic symphysis are brought closer together. So during laparotomy, because the distance is decreased, so closing during a laparotomy is a midline incisions, right? So the tension is less, so it's easier for the surgeon to close during laparotomy. Non-sliding mattresses are recommended to prevent the patient from sliding cephalad, right? Or if turned downwards, sliding caudal too. Shoulder braces are not recommended because they cause risk of injury to the brachial plexus. Now tilting the supine patient head down, that is the Trendelenburg position, which is head low, often increases venous return, so it increases the BP. It improves abdominal exposure during laparoscopic surgeries because all the abdominal content gets pushed cephalad, and it can help prevent emboli basically and it facilitates central line cannulation because the vein fills, the jugular vein fills, so it becomes larger, the internal jugular vein, so it becomes easier to cannulate the vein. So the Trendelenburg position has various cardiovascular and respiratory changes. So in the head low position, your intracranial pressure, intraocular pressure, and um, central venous pressure increase, and there can be congestion and swelling of the face because of pooling of blood in the face. There can be congestion and swelling of the larynx and tongue. So with that, you can lead to airway obstruction. So while taking out the tube, one must confirm an air leak before pulling out the endotracheal tube. Otherwise, it can lead to airway obstruction and loss of airway of the patient if the patient is not able to maintain the airway. Then the cephalad movement of the diaphragm and abdominal viscera against the lung decreases the functional residual capacity and pulmonary compliance. So in spontaneously breathing patients, this will increase the work of breathing. Mechanically ventilated patients, the airway pressures will be increased. In these patients, again, head low, the stomach lies at the level above the level of the glottis, so chance of aspiration is there. Reverse Trendelenburg is basically your head up tilt. It is often, again, for laparoscopic surgeries. It is useful because it shifts abdominal contents down. And here with this position, basically there can be pooling of blood in the lower limb, so the BP can decrease, so perfusion has to be maintained, BP has to be maintained. And in all the positions where the head is at a different level than the heart, the effect of hydrostatic gradient on cerebral, arterial and venous pressure should be carefully considered. Lawn chair position, it is better tolerated by patients who are awake, and like I already told you all about it. The frog leg position, again it is tolerated by patients who are awake. It allows access to the perineum, medial thigh, genitalia, rectum. It's not usually used. And care has to be taken to minimize stress on the hips, basically, otherwise there will be severe post-operative pain. And care has to be taken to prevent dislocation by supporting the knees, so the knees have to be supported to prevent dislocation. These are the complications. One is pressure alopecia. So prolonged pressure can lead to hair loss, ischemia of the hair follicle, and alopecia. Then if there are any of the monitoring equipment like the cables, or the one is the cables, and the ECG leads and all are little thickish. So in certain positions, if the patient is resting too long on these cables, etc., it can lead to lumps. Backache, so the normal lumbar lordotic curvature is lost, and because of the loss of tone of the paraspinous musculature, and hence uh, with muscle relaxation, so it can lead to backache. And of course, peripheral nerve injury, your ulnar neuropathy is the most common. Brachial plexus actually is the most common, and need not be that all nerve injuries are because of positioning. Now coming to your lithotomy position. So the classic lithotomy position is frequently used basically for your gynecologic degree. So hip flexed 80 to 90 degree from the trunk, and the legs are abducted 30 to 45 degree from the midline. Sorry. Okay. So the legs are abducted 30 to 45 degree from the midline, and the hips are flexed. Uh, hips are flexed 80 to 90 degree from the trunk. The knees are flexed until the lower legs are parallel to the torso. So the knees have to be flexed until, so the lower limb, basically the lower legs have to be parallel to the torso. Okay. The stirrups will hold the legs. Basically the kind of stirrups are candy cane, knee crutch, and calf support. These are the types of stirrups. So initiation of the lithotomy position requires a effort, coordinated positioning of the lower extremities by two assistants to avoid torsion on the lumbar spine. Okay, so it requires coordinated. It has to be done together. So the lowest extremities have to be placed into the lithotomy position by two assistants together, not one by one. This is to avoid torsion on the lumbar spine. Both legs should be raised together, flexing the hip and the knee simultaneously, and the lower extremity should be padded to prevent compression against the stirrups. Okay, and the hands have to be positioned in such a way to prevent entrapment in any of the moving sections of the surgical table. I will explain that here. So after the surgery, the patient must be returned to the supine position in a coordinated manner, basically, and a reversal of the initial positioning. So if the hips and the knees have to be flexed again, and then patient's legs have to be made supine, and this all together by two assistants, a coordinated effort has to be done to bring the patient back to normal position. So proper positioning of the hand is very important during lithotomy. So basically during lithotomy position, the foot end of the table is usually lowered, right? So that the surgeon can sit over here. So the surgeon sits over here and performs the surgery. So the foot end of the table is usually lowered. So when raising the foot end of the table at the end of surgery, the attention to the, so when this foot end of the table is raised after surgery, attention has to be paid, must be paid to the hands to avoid crush injury of the fingers. So if the hands are incorrectly placed, so mostly the hands will be abducted, but if the hands are placed by the side of the patient, it has to be very careful. You have to be very careful when making the table straight, because it can lead to crush injury of the fingers. So for this, when patients, that is why when patients are in lithotomy position, the recommended position of the arm is on the armrest by the side. Okay, so that the patient's hands are visualized and confirmed to be safe. So basically the recommended position in lithotomy, arm position, in lithotomy is arms by the side of the patient. Yeah, so that is the recommended position. See, this is again very dangerous. The arm hanging, as you can see, it is not advisable. This arm hanging, this is wrong, because the patient can, when the, if the patient puts his hand here, when the footrest is brought back up, there can be compression. So there are various physiological changes that occur with the, basically with the lithotomy position. So when the legs are elevated, venous return increases, which causes an increase in cardiac output, right? So basically venous preload increases, causing an increase in cardiac output, but lesser extent the cerebral, venous and intracranial pressure. Intracranial pressures are raised. So the cerebral and the intracranial pressures are not raised even because of this venous return in healthy patients. Uh, Also, the lithotomy position causes the abdominal viscera to displace the diaphragm. So basically, the abdominal viscera displaces the diaphragm upwards, because it's supine and legs are raised. So the abdominal contents are basically causing pressure on the diaphragm. This will lead to reduced lung compliance and decrease in tidal volume. Basically, the FRC also decreases and tidal volume also decreases. So if there is obesity or any large abdominal mass like a tumor or gravid uterus, abdominal pressure will increase enough to obstruct the venous return to the heart. So along with causing upward diaphragm displacement, these large masses can also cause can cause significant obstruction of the venous return to the heart. Uh, Also, the normal lordotic curvature of the lumbar spine is lost in the lithotomy position, which can increase back pain quite a bit. And it can lead to your lower extremity compartment syndrome. Now, this lower extremity compartment syndrome, I will take it here, okay? Because there is no place here to write. Okay, so your lower extremity compartment syndrome. So basically, the injury to the common peroneal nerve is the most common lower extremity nerve injury. Okay, this is the most common nerve that is involved. Then the cause of the injury was said to be compression of nerve between the lateral head of the fibula and the bar holding the legs. So compression of the nerve between lateral head of fibula and bar holding the legs. This was the most common cause uh, of the injury. Now, when the candy cane stirrups were used, special attention had to be avoided to basically this compression. Okay, so basically this compression is more common with candy cane stirrups. Thin patients, because there is less padding. Smokers, because more prone to narrowing of the arteries anyways, decreased blood flow, and prolonged duration of surgery. Okay, so this compartment syndrome is more common in these people. Um, of course, this has decreased considerably because of awareness and great care that is taken by the anesthesiologist. And surgery longer than 2 hours is significantly associated with this condition. So basically, surgery more than 2 hours is associated with this condition. Uh, so lower extremity compartment syndrome is rare and it is caused by decreased perfusion that is associated with lithotomy position. So basically, arterial pressure decreases by the local arterial pressure decreases by 0.78 millimeter mercury for each centimeter leg is raised above the right atrium. So every centimeter the leg is raised above right atrium, the pressure basically the local arterial pressure decreases by 0.78 millimeter of mercury. Okay. Uh, so the compartment pressure initially increases in the lithotomy position. So basically, one is this, that every centimeter the leg is raised above the right atrium, the local pressure decreases, and then there are many other causes that are associated with this decreased perfusion pressure that can lead to the cycle of basically there will be ischemia, edema, and rhabdomyolysis initially. So uh, this basically leads to ischemia, edema, and rhabdomyolysis. lysis. Okay, so this is what happens, and this is like a vicious cycle. So in any reperfusion, okay, so after an ischemic injury, any reperfusion will further increase the edema and exacerbate the problem. So fasciotomy, the treatment is basically fasciotomy, right? So for this compartment syndrome, fasciotomy is the treatment. Okay, and for this fasciotomy basically is done when the pressures are measured to be greater than 30 millimeter of mercury. So when the compartment pressure is more than 30 millimeter of mercury, that's when fasciotomy is basically done. And irreversible, so there will be irreversible damage when pressure is more than 50 millimeter of mercury, right? So in positions, in basically in surgeries that are taking more than 2 to 3 hours, the leg should be lowered in between the surgery and then repositioned again to avoid this compartment syndrome. Also, risk factors such as obesity also compromise oxygenation because of uh, it known to compromise tissue oxygenation like blood loss, peripheral vascular disease, hypotension, reduced cardiac output are seen with all these patients. So even in obese patients, they will have some other problem, right? So basically their cardiac output and all will be all there. So this further leads to a uh, can lead to compartment syndrome. Now coming to your lateral decubitus position, uh, so the act of positioning the patient in the lateral decubitus position basically involves the cooperation of the entire surgical staff. This is to prevent injuries, right? So the patient's head has to be kept in a neutral position. So the concerns with lateral decubitus position are head has to be in neutral position. There should be no stretch to prevent on the neck to prevent injuries to the brachial plexus. So head support may be needed. Then the ear should be checked. Dependent ear has to be taken care of. Dependent ear to avoid pressure necrosis. The eyes have to be secured and closed before positioning if the patient is asleep. And dependent eye also must be uh, checked for external compression, and of course the axillary roll has to be taken care of. The axilla has to be taken care of. Okay, so these are the concerns. So basically the lateral decubitus position is most frequently used for surgeries involving the thorax, retroperitoneal structures of hip. So basically your thoracotomies and all that. So your thoracotomy, retroperitoneal structures of hip. So the patient's head must be kept in a neutral position to prevent lateral rotation of the neck and stretch injuries to the brachial plexus. So the head, like I said, has to be kept in neutral position to prevent lateral rotation of the neck and any stretch injuries. Head support may be required, so a head ring may be required to support the patient. Then dependent ear should be checked to avoid undue folding and pressure. Okay, otherwise it can lead to ischemia. So they should be the dependent ear should be checked. The eyes should be taped before repositioning if the patient is asleep. Otherwise, while repositioning, if the eyelid gets raised or something, there can be damage to the eyeball. The dependent eye again must be checked for external compression. There should be no compression on the eyeball. It can lead to post-operative visual loss. And then the compression of the dependent axillary structure should be checked for. So regardless of the technique, the pulse should be monitored in the dependent arm for early detection of compression of the axillary neurovascular structure. This will avoid compartment syndrome again, right? This will avoid compartment syndrome. Basically, the pulse should be monitored in the dependent arm. Now, vascular compression and venous engorgement in the dependent arm can affect the pulse oximeter readings, and a low saturation may be an indication of compromised circulation. Okay. Now, when a kidney rest, so now the axillary roll, right? What we spoke about the axillary roll. Sorry. The axillary roll should never be placed in the axilla. It is basically placed to keep the axilla free. Okay, the purpose of the axillary roll is to keep the axilla free. So it is usually placed caudal to the dependent axilla. Okay. So this is to ensure, so it is usually kept caudal to the axilla. This is to ensure that the weight of the dependent thorax this is to show that the weight of the dependent thorax is borne by the chest wall caudal to the axilla. This is to avoid injury to the structures in the axilla. It is borne by chest wall, that is caudal to the axilla. So even though it's known as axillary roll, it is not placed in the axilla. It is placed caudal to the axilla, so that the axilla is kept free, so that the structures in the axilla do not get damaged. And this roll is basically kept caudal to the axilla. Sorry. So when the kidney rest is used, so basically a kidney bridge will be used like to get better vision. So when the kidney rest is used, it must be placed under the dependent iliac crest to prevent any inadvertent pressure on the of the inferior vena cava. So if it is placed here like above the iliac crest, I'm sorry, it can cause compression of the inferior vena cava, and it can cause decreased venous return, basically hemodynamic instability. So it must be placed under the dependent iliac crest to avoid compression in the inferior vena cava. Then finally, a pillow or padding is gently placed between the knees with the dependent leg flexed to prevent excessive pressure on bony prominences and stretch of the lower extremity nerves. So the lower limb is flexed a little, and pillow is placed between the legs to prevent any, uh, you know, uh, any excessive pressure on any bony prominence. So the lateral decubitus position is also associated with many pulmonary changes, okay, pulmonary compromise. So in a mechanically ventilated patient, remember this, the patient is on ventilator. Okay. First of all, there is the lateral weight of the mediastinum. So it is there is a dependent part. So the non-dependent part, there is the lateral weight of the non-dependent mediastinum. There is cephalar pressure of the abdominal contents of the dependent lung. So the cephalar pressure of abdominal contents on the dependent lung. So because it's to one side, so all the abdominal contents are causing pressure on the dependent lung. This will favor overventilation of the non-dependent lungs. Because there is so much of pressure on the dependent lung, the non-dependent lung gets overventilated. However, the pulmonary blood flow will be more to the dependent lung. This is because of gravity, right? So because of gravity, there will be more pulmonary blood flow to the dependent lung. So blood flow is more to the dependent lung. Okay, this is one point, and the other point is ventilation is more in the non-dependent lung. Ultimately, these two will lead to your ventilation perfusion mismatch. Okay, so ventilation perfusion mismatching worsens. So patients may be flexed in the lateral position to spread the ribs during thoracotomies. So the table might be flexed, or to improve exposure, for renal surgeries. The point of flexion and the kidney rest, if there is a kidney rest, should lie under the iliac crest rather than the flank or rib cage, right? So wherever the the table will be flexed in the sense, so this is the table will be broken like this in the center. So the iliac crest, the point where the flexion is performed, the kidney rest should lie under the iliac crest rather than the flank or the rib cage, right? So the kidney rest should lie at the level of the iliac crest, not the flank or the rib cage. Otherwise, it will cause compression on the dependent lung. This position, the lateral decubitus, is often accompanied by the reverse Trendelenburg, that is your head-up position. So various complications that occur with the reverse Trendelenburg position also, will be seen, like the pooling of the venous blood in the lower extremities, hypotension, etc. Now coming to the prone position. So basically, prone position is primarily used for surgical access to the posterior fossa of the skull, the posterior spine. So spine surgeries, a posterior fossa of the skull, the buttocks and perirectal area and lower extremity. So any surgery on the back, the prone position is used. As with the supine position, if the legs are in plane with the torso, so if the legs and the torso are in the same plane, with the supine position, since the heart and the brain the head are at the same level, hemodynamic reserve is best maintained in this position, right? The pulmonary function may also be superior to the supine or lateral decubitus position so as long as there is no abdominal pressure and the patient is positioned properly, the ventilation is actually much better in this position. Okay, so in this position, the legs have to be padded. So the legs should be padded and flexed slightly at the knee and the hip. So the legs have to be padded to prevent any compression of the bony prominences. Flex slightly at the knee and the hip. And the head may be supported face down with its weight borne by the bony structures turned to one side. So the head is turned to one side and all the bony structure to that side will bear the weight of the head. In this case, the eye position has to be checked. It has to be seen that the eyes are free, otherwise it can lead to post-operative visual loss. So both arms may be positioned to the patient's side and tucked in the neutral position, or placed next to the patient's head on an armboard. So both arms either can be tucked here by the patient's side, okay, or they can be placed like this in a Superman position, basically with the arms faced out, known as the Superman position. So here also abduction of the arm greater. So in this cases, abduction of the arm, because of the effects of alteration in shoulder position on the brachial plexus, in this position, abduction of the arm Greater than 90 degrees is better tolerated in the prone than the supine position. So because the patient is in the prone, the abduction of the arm more than 90 degree in this position is better tolerated than in the supine position. Then elastic stocking should be applied for long surgeries because to prevent venous pooling, especially if there's any flexion occurring. So extra padding under the pillow should be provided to prevent compression under the elbow, to prevent compression of the ulnar nerve. Arms again should not be abducted greater than 90 degree to prevent excessive stretching, but even if they are, it is better tolerated than supine. Right? Then elastic stockings and active compression devices are needed to minimize pooling of blood in the lower extremity. Now, when general anesthesia is planned, the patient is first intubated on the stretcher. Excuse me. So, patient is first intubated on the stretcher and all intravascular access is obtained. Endotracheal tube is secure to prevent any dislodgement, and because when the prone position, the tape with which so endotracheal tube is usually secured with a tape, but the tape can loosen because of the excess secretions that are coming out for the patient. So it has to be secured properly to prevent loosening due to secretions coming from the draining from the saliva in prone. So with the coordination of the entire operating team, so a minimum of 5 people, the patient is turned prone onto the operating room table. So with the coordination of the entire operating room team, the patient has to be turned prone onto the operating room table, keeping the neck in line with the spine during the move. So the neck shouldn't flex or extend much. Neck has to be kept in line with the spine, and 5 people in total in one the shot. The patient has to be turned prone, all in synchrony. The anesthesiologist is responsible for the head end of the patient. And of course, once the patient is placed in that position, everything has to be checked. The air entry should be checked again to see if the tube is dislodged. The tube should be checked whether it's been kinked, and the tube is usually supported by a Y piece from the connected to the anesthesia circuit. So it is recommended to disconnect. So basically the blood pressure cuff, pulse oximetry monitors are basically disconnected so that there is the venous the arterial and venous lines also are all disconnected to prevent dislodgement and any because dislodgement, then again securing an IV line and all that. So to prevent any dislodgements, all the monitors and the arterial venous lines are disconnected, and as soon as the patient is put prone, the full monitoring should be reinstituted as soon as possible. Yeah, endotracheal tube position should be checked and ventilation should be reassessed immediately after positioning. The face has to be rechecked if any patient after positioning, to see if any compression is occurring to the eye, etc. The prone position leads to this post-operative visual loss, which is common with this position. So the prone position leads to your prone position is commonly associated with the So patients with cervical arthritis or any cerebrovascular diseases, lateral rotation of the neck may further compromise the carotid or vertebral arterial flow or jugular venous drainage. So care must be taken in these patients too. So with any cervical arthritis or any cerebrovascular diseases, again compromise too much of neck rotation it can cause block of the carotid or vertebral arterial flow and jugular venous drainage, leading to congestion within the brain and further damage. So regardless of the technique employed to support the head, the eyes, the face and the airway must be checked periodically. So how, even though it is secure, it has to be checked periodically to ensure that the weight is borne only by the bony structures and that there is no pressure on the eye. Otherwise, it will lead to post-operative visual loss, which is again medical legal. Proper positioning is verified by frequently and has to be noted down in the anesthesia record. Then, because the abdominal wall is easily displaced, the external pressure on the abdomen may elevate intra-abdominal as well as intrathoracic pressure in the prone position. Okay, so abdominal wall is easily displaced, so any external pressure on the abdomen can elevate the intra-abdominal and intrathoracic pressure. So hence, careful, the abdomen should always hang loose. Because of this, abdomen should hang loose. So abdomen should hang loose ideally. Now during posterior spine surgery, low venous pressure is desirable to minimize bleeding and to facilitate. So during any posterior spinal surgery, this abdominal pressure has to be maintained. So it has to be, the abdomen has to be free, otherwise abdominal pressure can again lead to raised intraspine within the Battson's plexus. So within the venous plexus of the spine, it can raise the pressure and cause bleeding and obliterate the field of surgery. Because this abdominal pressure transmits the pressure to the abdominal and spinal vessels, including the epidural vein. So all these lack valves, right? So it, so basically it will impede the field of surgery. Now this abdominal pressure can also impede venous return by compression of the inferior vena cava and decrease cardiac output. So it may push the diaphragm cephala, decrease the functional residual capacity and pulmonary compliance, and increase peak airway pressure, any external compressor. It can impede the venous return because of compression on the vena cava and decrease the cardiac output. So careful attention has to be paid that the abdomen hangs freely with and moves freely with respiration. Now, to prevent tissue injury, pendulous structures like the male genitalia, female breasts, and etc. should be clear of compression. The breast should be placed medial to the bolsters, right? So these pendulous structures should be taken care of, that there is no compression on them. Now, the prone position presents special risk for especially morbidly obese patients whose respiration is already compromised, and it may be difficult to position these patients quickly, so there may be a delay, so the ventilation might further get compromised. So it may be necessary to discuss alternate positioning options with the surgeon in these patients. Now coming to your sitting position. So the sitting position, although infrequently used because it is perceived, the risk of venous and air embolism is perceived to be very high with this position, so it is not frequently used. But it offers advantage to the surgeon in when they approach the posterior cervical spine and the posterior fossa. So basically this for neurosurgeries. Yeah, so the posterior cervical spine and posterior fossa when needs to be accessed, this position is usually used. The main advantage of the sitting position over the prone position for neurosurgeons, so for the cervical spine, posterior fossa, even the prone position can be used. But the main advantage with the sitting position over the prone position is there is excellent surgical exposure, there is decreased blood loss because of the venous healing. There's reduced, like I said, decreased blood in the operative field, decreased perioperative blood loss, and of course we have superior access to the airway because the airway is in the prone position. It is very difficult if there is dislodgement. You will have to make the patient supine and not intubate the patient in the prone position. Whereas with the sitting position, it's very easy to make this patient supine immediately. There's no facial swelling that is seen with the prone position because there is no pooling of blood in the face. no swelling of face or the lips or the tongue or the airway. So the risk of airway obstruction is lesser with this patient. There is improved ventilation, particularly in the obese patient. So in the obese patient, this position would be ideal, because in the prone patient, in the case of prone, again there is obese patients usually will have the airway pressures will be very high, and this, along with the pulmonary compromise that occurs with the prone position because of the pushing of the abdominal contents on the diaphragm, can worsen the condition of the obese patient. So this uh, position is preferred in the obese individuals. Now, the head may be fixed in pins for neurosurgery or taped in place with adequate support for other surgeries. So the head has to be fixed in place, otherwise it will hang. So either with pins or it is taped. The arms are supported to the slight point of elevation of the shoulders to avoid traction on the shoulder muscle. So slightly elevated shoulders, otherwise there will be traction, right? And also to prevent stretching on the neurovascular structures. Knees are slightly flexed for balance to reduce again stretching on the nerves and avoid traction on the muscles, and the feet are supported and balanced. So slight flexion and elevation of the limbs is required to prevent damage to the nerves and muscles. Because there can be pooling of blood in the lower body, these patients are particularly prone to hypotension. Now, head and neck surgeries has been associated with complications during surgery to the posterior spinal skull in the sitting position. So, excessive cervical flexion. So, during the cervical surgery, excessive flexion has adverse consequences. So, it can impede the arterial and venous flow, causing hyperperfusion or venous congestion of the brain. So, because of excessive flexion, it can cause obstruction of the venous flow. Yeah, it can get king. The jugulars can get king, and this will cause hyperperfusion, and it can cause venous congestion because the blood is not draining from the brain too. So it may impede the normal respiratory excursion, and excessive flexion can also, so too much of flexion of the neck for the surgical for the cervical spine, it can obstruct the endotracheal tube and cause significant pressure on the tongue, which can lead to macroglossia, and later on during extubation can cause the complement. So with macroglossia there can be airway obstruction because the tongue will be against the hard palate. So kinking of the tube has to be looked for during cervical spine surgeries. The brain perfusion has to be maintained and macroglossia has to be looked for. So generally, to prevent this macroglossia and endotracheal tube kinking and this hypoperfusion, at least a 2-finger distance between the mandible and the at least a 2-finger distance between the mandible and the sternum is recommended for a normal size adult. Okay, so the patient should not be positioned at extreme range of motion. So 2-finger distance between the mandible and the sternum. So now, because of elevation of the surgical field, so the head is elevated above the heart. The inability of the dural venous sinuses to collapse because of their bony attachments can lead to a venous exit. So because the head is above the level of the heart and the sinuses cannot collapse, the blood is drained, so air embolism can occur, which presents with arrhythmia, desaturation, pulmonary hypertension. The airway pressures will go up on the ventilator. There can be circulatory compromise and cardiac arrest. So that's it, guys, for today. That was class on positioning. We have completed it. Tomorrow we'll have a quiz on positioning. I've revised the entire topic for you all, so I expect you all to be well prepared tomorrow. I shall see you all tomorrow. So please do use my code SASHA. Avail your 10% discount with the bell icon, and guys, subscribe. Start preparing soon. See you all.